Hello everyone and welcome. My name is Jen Nolan and I am the Programs Manager at Arthritis and Osteoporosis Victoria. Arthritis and Osteoporosis Victoria is a not-for-profit community-based organisation which aims to achieve the best possible musculoskeletal health and well-being for the population. In a recent consumer needs analysis undertaken by Arthritis and Osteoporosis Victoria, people with fibromyalgia indicated more than any other condition-specific group how their condition impacted across various aspects of their lives, including their work life, social life, or simply in the difficulty they experienced in managing of day-to-day activities. I would now like to warmly welcome and thank Dr. Geoffrey Littlejohn, who will be our presenter for today. Dr. Geoffrey Littlejohn is Associate Professor of Medicine at Monash University, Director Emeritus of Rheumatology at Monash Medical Centre at Southern Health, and Adjunct Professor Edith Cowan University in Perth. Dr. Littlejohn has published extensively on many aspects of fibromyalgia and has presented locally and internationally on the topic over many years. Before asking Geoff to commence, I just have a couple of housekeeping issues to run through. First of all, if you have any technical difficulties during the webinar, please refer to the message box on your screen. If you are unable to hear the audio through your computer, please dial in via the number provided here on the screen and use the relevant passcode. If you are listening via the phone, you will notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, can I remind you that whilst Geoff will answer questions at the end of his presentation, you can actually type questions for him at any time. Can I suggest that you don't leave your questions to the last minute in case we run out of time, as we will aim to finish strictly at 1:30 p.m. Eastern Standard Time. Finally, I would be very grateful if all participants could take a moment at the end of the webinar to complete the exit survey, as this information will greatly assist us in evaluating this webinar and planning future activities. Without further ado, I'll hand proceedings over to Geoff. Thanks, Geoff.
Thanks very much, Jen, and good afternoon to all the participants and listeners to this webinar. I'm very pleased to be participating, and I really am pleased to be talking about the topic of fibromyalgia. I think our title was Understanding Fibromyalgia, and this is quite a job sometimes because it's a difficult condition to really get to full grips with at times. So over the next 30 to 40 minutes, I'll be talking about aspects of fibromyalgia, and that might raise issues and points and concerns, which will allow for questions and comments later on. So we'll start off, see how we go. Now, a lot of people think that fibromyalgia is sort of a new phenomenon or a new name that's sort of been conjured up in the 20th century, sort of medicalisation of routine symptoms. But in fact, it's an old condition. It's been described throughout many ancient texts and books through the years. Perhaps the earliest one is this on the screen here from the Epic of Gilgamesh, which comes from the Euphrates Valley some 4,500 years ago. And in one of the texts on this particular book, the author describes links between sleep and strain and muscles and pain. And these are often common themes or common links that we see with fibromyalgia in many different descriptions. Back in those days, it wasn't called fibromyalgia, it was called probably something else. Let's have a look at some of the names that fibromyalgia has been linked to over the years, and there's about 60 or 70 names that different groups and different peoples have used to describe fibromyalgia, from muscle rheumatism, myalgia, sensitive deposits, soft tissue rheumatism, etc. And down here, the und hier syndrome that a lot of people dismiss fibromyalgia as, pain here, und here, und here. So a lot of these names have been around for a while and have sort of muddied the water, if you like, because people read different things and don't have a uniform approach to the problem. Now, about 30 or 40 years ago, in the mid-1970s really, some clinicians in Toronto, Hugh Smythe, who unfortunately died late last year, and Harvey Moldovsky, who was a psychiatrist, his colleague, looked at fibromyalgia from a different point of view. And they tried to link the clinical features of fibromyalgia with some of the sleep disturbances, if you like, that are in the background of many people with fibromyalgia. And they started to rewrite descriptions of fibromyalgia for the purposes of study and observation. Then Muhammad Yunus, who's a rheumatologist in the mid part of the US of A, described patients with fibromyalgia in a much more clear fashion and linked symptoms and signs more consistently, and described the condition in a new way back just before the 1990s. And he set the scene for the development of criteria to define the condition. And the first criteria that have been deemed to be very useful are the American College of Rheumatology classification criteria of 1990. So they came out in 1990, and they were used to classify people with fibromyalgia for the purposes of study. So they're not necessarily diagnostic criteria, but they're a grouping of common symptoms and signs which are useful for classification for research purposes. Then the next big breakthrough, if you like, in understanding or defining the condition was just a few years ago in 2010, when the American College of Rheumatology again put out some new criteria, and these were now diagnostic criteria. So they were felt to be criteria useful to diagnose the condition. And we'll look at some of these aspects of these criteria in a minute or so. So what are the clinical features of fibromyalgia? Essentially, we're looking at a condition that creates widespread pain and people have widespread tenderness in the body. But in addition, they have lots of other central features such as significant fatigue, significant abnormality of sleep, and significant changes in cognition, poor memory, poor concentration, not remembering where they put things and becoming a bit muddled, etc., more easily than normal. Plus a lot of other sensory symptoms, so tingling and numbness, irritability to noise or to light, and a lot of other sensory symptoms become more, have higher impact on the individual. And often in the background there's stress somewhere, and this is sort of a key to the theme of the talk I'm giving today, I guess, the central features that might magnify or amplify these sensations. So these are sort of the common things that we see in fibromyalgia. We talk about it as a chronic pain syndrome. Now, chronic pain syndrome is a bit of a catch-all term, but it really is saying, okay, this person's got chronic pain, there are definable descriptors of that pain, the patient has certain clinical features, but we don't really know the cause for the pain, so we call it a syndrome. And fibromyalgia is one of these chronic pain syndromes. And we talk about a phenotype, and the phenotype means that the presentation of the individual is very characteristic, and we can sort of pick a few features to put them together and say this is what that person's got. And again, I emphasise these key features of widespread pain, widespread tenderness, but also the other characteristics of emotional distress in the background, poor sleep, fatigue, muscular stiffness, and poor concentration. If you do surveys of patients with fibromyalgia, they'll link pain number one, because that really defines the problem. I guess pain is number one. But number two is fatigue, and number three is poor sleep. And those three are really standouts for the whole problem. The other things come at far lesser frequency. We'll talk about some of these things a bit more as we go along. But let's just look at the patients who are defined as having fibromyalgia. How common is this problem? Well, it's very common. In the community, just doing random surveys of communities in various parts of the world, and I think everywhere I've seen a survey come out from different countries, it's the same, from Turkey, from North America, from UK, wherever you look, Scandinavia, it's all about the same. And about 2 to 5% of people fulfill criteria, these American College of Rheumatology criteria for fibromyalgia. The 2% relates more to the initial criteria, and the 5% more to these latter criteria, the 2010 criteria, which are a bit more liberal in picking up a larger group of patients with the condition. Different groups have looked at the number of people who present to the family doctor, the GP, and 7.5% of people presenting to GPs have fibromyalgia as the key problem. About 10% of people presenting to specialists, and that might be to rheumatologists or gastroenterologists or neurologists with headache, tension headache, or bowel, whatever they've got, they also have fibromyalgia. And if you do random surveys of people in hospital wards, coming in with, say, heart failure, pneumonia and the like, about 1 in 5 have fibromyalgia. And if you look at patients attending doctors who specialise in musculoskeletal pain, like rheumatologists, you'll find 1 in 3 have fibromyalgia. So it's a common condition, but just in the everyday community, walking down the street, 1 person in 20 that you pass will have fibromyalgia. It might even be you if you look in the mirror. So it's common, 2 to 5%. It's also more prevalent in females than males, but some of this excessive percentage in females to males links to the tenderness part of the original criteria, because females are more tender than males on palpation anyway, even without fibromyalgia, and that sort of biases this tenderness definition a bit towards the females. So it used to be thought, yeah, maybe 9 to 1 females to males, but now probably it's a bit less than that, 5 or 6 to 1 females to males. And it's a bit of a forgotten condition in males in part. If you look at the prevalence across the community, in community studies across the years, so this is United States, you note that it becomes more prevalent in the midlife years, so the mid-years, then drops off a little bit as people age. If you look at a survey from Spain, it's a little bit different. There's much more higher prevalence rates in that early 30 to 40 to 50 age group, then dropping down. But children get fibromyalgia, very elderly persons get fibromyalgia, but not as common as the mid-years. So a typical characteristic group and groups that have often participated in clinical trials are females in the mid-years, say 40 to 55, and they're sort of where a lot of these studies come from, because it's common in those age groups. Key symptoms of fibromyalgia. I mentioned the number one symptom was pain. The pain is, it fluctuates. It's not as if it's there all the time. It might be bad some days, better other days. It might be described as a heavy, aching, toothache pain or a dull, burning pain. Different sort of symptoms will qualify the pain. The pain might be in different parts of the body at different times. It might be in the shoulder girdle or the neck or the back or the legs at different times, and sometimes it's sort of all over. So it does fluctuate quite a bit. Other sensory symptoms, I've mentioned people get these other increased rates of pins and needles and heaviness in the arms and clumsiness and feelings of swelling in the arms and hands, dryness of the eyes, light irritability, tinnitus in the ears, buzzing, and all those sort of things that are more prevalent than in people who don't have fibromyalgia. So it's not just a pain condition. It seems that lots of sensory input is amplified and not filtered out as it goes up into the brain to be processed. And in the background, the poor sleep, the fatigue, and again, these may dominate the patient, so it may be more the fatigue that's the problem rather than the pain. Fuzzy head, this cognition, this problem with thinking and concentration, the cause of that may be related to various pain chemicals that are released in the neurotransmitters in the brain, but it's a bit unclear as to the exact cause. Many people are distressed, and some have mood disturbance. It's worth noting that probably 20 or 30% of people might be depressed with fibromyalgia, but as I'll mention later, depression doesn't cause fibromyalgia. So this is one person. This is the fibromyalgia symptom mix, just to indicate that patients will have different levels of symptoms with fibromyalgia, and each patient is different. So this particular individual patient rates their pain at about 8 out of 10, their fatigue at 6 out of 10, but their irritable bladder symptoms at about 15 out of 10. So there's a mix of different symptoms that are causing a bigger general picture in this particular individual. So if you were to treat this person, they'd probably be coming along to you and saying, my pain and fatigue are bad, so that's what you might focus on. Or if you're a physical therapist, you might say, gee, they're pretty stiff and that needs to be treated, so you'd focus on that as well. Someone else might say, gee, they're not thinking well, let's sort of work out how we can help that, etc. So we need to sort of target our therapy to the key symptoms, which do vary and fluctuate quite a bit in the individual. In addition, people with fibromyalgia have comorbidities, so about 30 to 50% of people with fibromyalgia will have another illness or another condition, such as chronic fatigue or irritable bowel or bladder, very common. Regional pain syndromes like neck pain, back pain symptoms. Restless legs is common. Sensitivity to various drugs and chemicals. Some people are very sensitive to perfume. Some people are sensitive to drugs and get reactions very quickly, making it harder to tolerate medication. Hypotension, neurogenic hypotension, dizziness and nausea, they're all more common in fibromyalgia. And about 30 to 50% have fibromyalgia plus one of these other things, overlapping comorbidities. And we think of fibromyalgia often as the elephant in the room, and this elephant saying to the psychiatrist, I'm right here, I'm right there in the room, and no one even acknowledges me. So fibromyalgia is often there with lots of other conditions that we see. It's far more common in patients with rheumatoid arthritis, lupus, osteoarthritis, degenerative back or neck disease, other chronic illnesses, chronic hepatitis, AIDS. All of these groups have been looked at for fibromyalgia, and high rates of fibromyalgia exist in these conditions. So it's as if it's another dimension to a lot of other chronic illnesses, and we might be treating someone for one condition that we know they've got, but in addition they've got the symptoms of fibromyalgia, which might need individual treatment. It has a very high health impact. This is a study done by Kay Brand from Perth during her PhD thesis, and this shows, let's look at it this way, this is the mean level, this top line, the mean level of Australian norms for the SF36 quality of life instrument, looking at the different domains of physical function, bodily pain, general health, vitality, emotional, etc. And this bottom line is the fibromyalgia patient scoring, 88 patients scoring very low levels of quality of life compared to people who are regarded as normal in Australia. So a very high impact on everyday, diverse amount of everyday features and symptoms. And if you compare fibromyalgia, the same group, to chronic obstructive pulmonary disease, end-stage renal failure, pulmonary hypertension, which is high blood pressure in the lungs, which gives severe shortness of breath. If you look at the fibromyalgia, they're just as bad or worse than all of these other groups that we consider to be very high-impact disorders. So fibromyalgia does have a huge impact on the individual, and this is a large number of just randomly selected patients with fibromyalgia. Does it persist or does it go away? This is an old sort of study from America where they looked at patients who were going to hospital clinics with fibromyalgia, 700 patients, and the first assessment is the yellow dot, and the second assessment is the purple dot, and they're really just making the point that things don't change too much in regard to the different dimensions or domains of the fibromyalgia, the health, the pain, fatigue, sleep, etc. Of these individuals. So these are patients going to hospitals. This is a study from 20 years ago, and maybe they were just getting the same old treatment and not really getting a good current approach to the problem, but they didn't do too well. And then we contrast that to another study done in Australia where patients were seen with fibromyalgia 2 years earlier and then reviewed, 44 patients, not a large group, but of that group, around half or just over half were better and a half were the same. And these patients were just seen by a rheumatologist once. They were given stress advice, exercise advice, and some self-management techniques in education, and then reviewed without any other intervention 2 years later. And a lot of people do well. They just need to know what's going on, how to self-manage. Others don't do as well. They need more intensive or added treatments. In fibromyalgia, one of the key things is this tenderness, and it's a clue to the underlying cause. The pain threshold is low in fibromyalgia. Patients with fibromyalgia have normal sensation, so it's not a neurological disorder, but the function of the pain system changes. And this is sort of a way of showing this. These are normal people. The red is fibromyalgia, or the magenta is fibromyalgia. They detect sensations normally. There's no neurological problem, but they will get pain with far less pressure. Say if you're pressing with your thumb or finger anywhere in the body compared to people without fibromyalgia. So this is the lowered pain threshold throughout the body. Pain threshold is the first stimulus which records pain in an individual. And because of that, there were some, the American College of Rheumatology said, well, there's common spots in the body that are a little bit more tender than other spots, so why don't we look at those as areas that we can try to assess pain threshold in, and these are called the tender point spots. And they're somewhat arbitrary and just picked up empirically over time, and they're basically around the neck and shoulder girdle and in the low back and buttock areas, and sort of hints that some of the process might be coming from the low back and low neck to generate some of these tendon areas. So they're the so-called tender points that you read about. That's one clinical sign. People with fibromyalgia have lots of areas that are tender, but the areas between the tender points are also abnormally tender. It's just that the tender points are more tender than they would otherwise be in normal people. So pain threshold drops. They also get this sign of dermatographia. So you lightly stroke the skin with the tip of your fingernail just down the back, and within 10 seconds you'll see this big red reaction, so-called dermatographia. And that links to release of a neurotransmitter substance called substance P, which dilates up the blood vessels in the area. So it's a visual link to the pain mechanism. I find it quite useful to show to patients that, yeah, something's going on in your pain system, and that links to abnormal neurotransmitters within the pain system. I mean, normal people get mild levels of this, but fibromyalgia patients get much more, so it's a spectrum. So to look at the diagnosis of fibromyalgia, we said that these things come together: widespread pain, widespread tenderness, and other characteristic symptoms that we've been defining. And we have to be very careful when looking at diagnosis to rule out or look at other possible causes that might mimic fibromyalgia. So someone might have hypothyroidism, someone might have, they might be menopausal and estrogens dropping, and that might be causing a lot of these symptoms. It might be, a very serious infection or malignancy or something causing these things, calcium disturbance. There's a few things that can cause mimics of fibromyalgia that we need to rule out when we do our evaluation. If we look at the American College of Rheumatology 1990 criteria, they linked a large number of these tender points in the patient to ongoing symptoms of pain in various parts of the body: widespread pain, widespread tenderness, and that was the diagnostic criteria. They've been very useful for 20 years. There's about 6,000 papers being presented based on these criteria to work out what fibromyalgia is all about. So they've been very useful. But it was noted that a lot of people don't do these tender point examinations, or they're not too sure about where to push or how hard to push or what it all means. And so that's why the American Rheumatology Society changed their criteria 2 years back. And I'll go into that in a minute. At the back of fibromyalgia, there's often a lot of stress and strain, and we talk about these things as yellow flags, and this is Pandora opening her box, the fibromyalgia box. And if we look into the background of many people with fibromyalgia, we'll find a lot of stress-related type issues, such as maybe a family history or a previous pain problem, work or personal stresses, spinal injury, vulnerable personalities, poor coping or a catastrophizing sort of approach to life, substance abuse, other medical conditions. There's lots of things in the background, and this needs to be remembered. So here we go with our diagnosis. We've got a contemporary clinical approach. So I like to see patients with fibromyalgia have widespread pain complaints, widespread tenderness, but also other characteristic symptoms. And just getting back to this new diagnostic approach of the American College of Rheumatology, they're saying you can link widespread pain just to these other characteristic symptoms without worrying about the tender points that a lot of people have become a bit too concerned about. And these criteria define the same population as the tender point patient criteria. They're based on the tender point criteria. So patients with these criteria will also have all the tender points we've mentioned. So I like to, as I said, look for widespread pain and tenderness, plus also the other characteristic symptoms. This is called the so-called 2010 no-touch criteria. They can all be assembled, and you can, through computer analysis, work out how much pain you need, how much symptoms you need, and get scores, and those scores will dictate whether people fulfill criteria for fibromyalgia, diagnostic criteria. I won't go into all the ins and outs of it, but it's pretty simple when you get down to it. Actually, I'll go back to that slide. We're looking for widespread pain, and we're looking for these symptoms: high levels of fatigue, high levels of poor sleep, high levels of poor cognitive function, and high levels of other somatic symptoms. And these other somatic symptoms initially were everything you could think of, but they were reduced down to abdominal pain, depression, and headache. If I go to the next slide, We can get a chart of all those things. We can chart out where the patient's got their pain. Then you add up how many pain regions are present. That gives you an index of pain. And you ask how much fatigue, 0 to 3, 3 being bad, 0 being nothing. You can add them up. Have they got a bad? And then you give them a score, and you can say they define criteria for fibromyalgia. This could be quite useful when you're evaluating patients with lots of different physical or other conditions. They can just fill out this sheet and sort out whether they might have high levels of tendency towards fibromyalgia, which then might make you modify your therapy towards that particular option. With these new criteria, many of the old conditions that we called regional pain, like whiplash or RSI or low back pain syndromes, etc., if there's enough pain regions, if there's 3 regions of pain involved, plus high levels of those somatic symptoms, they'll now fulfill criteria for fibromyalgia. So we might see sort of a shift in the way we see such individuals over time and talk about fibromyalgia more. So lots of things might be fibromyalgia. It's going to become a bit more frequent using these new criteria. So just to summarise, we now think of the newer criteria, widespread pain and other characteristic symptoms, as being a useful way to move forward, but not forgetting that people should be tender as well. So there's body-mind implications there, poor sleep, fatigue and cognition's up in the brain, widespread pains in the body. You mean that's mine. This is from the Path Out of Pain website from Rosemary McIndoe. Now, fibromyalgia is not myofascial pain syndrome. That's a condition where there's abnormal bunched up muscles that cause pain and generate pain, and that's a separate condition to fibromyalgia, but this myofascial pain is more common in fibromyalgia. What triggers fibromyalgia? Often there is a trigger. About 80% of people recall something that started fibromyalgia, maybe an injury, an infection, some life predicament, some other illness, maybe stress situation. So it's often been triggered by something which is identifiable to the individual. And that links a lot to psychological factors. I mentioned before that depression doesn't cause fibromyalgia, but it may result from it. There's increased rates of anxiety and depression in fibromyalgia, particularly if the person's a patient and not just a self-manager, not seeing any health professional. A lot of people have fibromyalgia without needing to see anybody. They're far less likely to be anxious or depressed. Many patients with fibromyalgia are distressed. Maybe there's some background life predicaments. And there's often there are links to genetic factors in this grouping of patients, particularly factors that link to monoamine metabolisms, such as the noradrenaline, adrenaline, serotonin type factors, which might influence psychology. The triggering stress that might have started fibromyalgia may have gone and been forgotten by the individual, and that needs also to be considered. So the key mechanism for fibromyalgia, there's no mechanism that's been linked to any biochemical, hormonal or other blood-related problems. Peripheral pain generators may be present, but they're not the driving force in fibromyalgia. But there are lots of things happening within the nervous system, in the pain-related nervous system of fibromyalgia. And we think psychological, in the broad sense of that term, like stress or distress, not disease like depression, but psychological mechanisms linked to brain responses, the way the brain tells the spinal cord how to work, increasing sensitivity within the spinal cord, and that relates to the clinical features. There's important links between the brain and the spinal cord, and there's 2 major components. There's a component that relates to opioids, and there's a component that relates to serotonin and noradrenaline. And as this component, the noradrenaline serotonin, links between the brain and the spinal cord that modify and modulate the pain system specifically in relation to fibromyalgia. Not an opioid-related system, but it relates to this serotonin noradrenergic control system from the brain down to the spinal cord. The pain probably does generate in the body, so there's probably amplification of pain from normal biomechanical factors in the spine, as I mentioned earlier, or maybe in the muscles, such as with trigger points, or maybe in the joints if someone's got osteoarthritis, which is a key driver of some fibromyalgia situations. So the pain system is active in these areas, but there's a modulation or upregulation of pain from changing the control of pathways from the brain, which then defines really the patient as having the fibromyalgia, situation rather than just a pure body pain generator such as trigger point. Might just duck through some of these because I notice the clock's ticking away. Yeah. I'll stay on this one. Sensitization seems to be the key mechanism of fibromyalgia. In the nervous system, sensitization indicates that it's the response to pain nerves is changed such that low, previously sub-threshold stimuli will now activate nerves. And this is sort of common in the nervous system, such as when we get a cough and keep sneezing with minimal stimuli, or get an itch, and just minimal stimuli get that itch going again, or a wheeze or a gag or photosensitivity. All of these things are sensitization type phenomena within the nervous system, and the pain nerves have that same characteristic, and they're very easily sensitized in life. And this is just an experiment which shows that sensitization in patients with fibromyalgia. If you apply a heat stimulus to fibromyalgia people compared to non-fibromyalgia people, you'll find that after about 20 stimuli, their pain system gets ramped up very quickly compared to a mild increase in sensitivity in a normal person. So there's increased sensitization of the pain nerves within the spinal cord in fibromyalgia, and that's modifying a lot of the different symptoms that might occur. And that translates into what's happening in the brain. So the brain also is overly sensitized. If you apply a stimulus to the hand, for instance, and measure it in fibromyalgia patients, you'll find it takes far less stimuli, say a very minimal stimuli here, to give a lot of pain in fibromyalgia, but not much pain in a normal person. A normal person would need a lot more stimulus to get the same degree of pain reactivity in the brain. This is measured by functional MRI scanning, and there's lots of these sort of studies that now show how much sensitization is happening within the brain. It happens on both sides of the brain and in lots of different areas, not just the traditional single pain-related areas of the brain. But the brain's also doing stuff from its own right, going downwards, so sort of top-down sort of stuff. And as I said before, psychological factors influence the neural control systems in the spinal cord, leading to sensitization. And simple things like poor quality sleep, like a young mother who's sleep deprived and whatever starts to get aching and fatigue and all those sort of things. That's sort of fibromyalgia. It's not sort of rocket science. It's just the way the body's reacting to that particular emotional distress situation. And there's different hormones and things that can be measured which change in that setting. Over that, I just want to mention some comments on management of fibromyalgia. The general principles of management sort of derive from our understanding of the top-down sort of approach and the way the body's a mind-body interactive system rather than just all the problem being in the body itself, in the muscles. So we think of management as being multimodal, and we choose from different strategies, and in any individual we might be better managing the patient with one strategy or another. But in general, we're thinking of physical strategies, psychological strategies, and perhaps pharmacological strategies. So you might need a lot of those, or might need just one of those in any one individual. We individualise our treatment as much as possible, trying to target what their main problem is. Perhaps it's their pain, perhaps it's sleep, mood, fatigue, stiffness, whatever. We try to sort of hone in on where their key problem is to diminish their symptoms. We have to be very flexible, and also we have to adapt our own approach and change our own strategies quite frequently in fibromyalgia. So the core things are education, exercise, psychology of different types, and that's often just talking to the individual. Simple explanation counselling is quite potent and powerful in fibromyalgia, as it is in other chronic pain states, and pharmacological interventions are improving. Now, fibromyalgia is not just one condition, as I've been alluding to. Different patients get different sort of types of fibromyalgia, if you like. There seems to be a final common pathway of a lot of inputs. This was one study, just to emphasise that, 97 patients. They had all their symptoms put onto sort of a computer program, and they sort of worked out the best fit for the key symptoms of tenderness, mood change, catastrophizing, like a psychological coping strategy, or a bad one, and pain control. And they found there were three groups in this particular study. people with moderate levels of those symptoms, some people who had very high tenderness and bad mood and a lot of catastrophizing, poor pain control, and others that had, a lot of good pain control, but a lot of tenderness, but not too much mood or catastrophizing, just different combinations. But I find that a little bit useful because in clinical practice, the typical patient, the most common patient, is managed usually through diagnosis and explanation, education, exercise, stress advice. That's sort of a typical grouping of approaches. But some people have a lot of psychosocial input. They're very difficult. Maybe it's a work cover situation. There's a lot of things going on that you really need a lot of team resources to better manage that particular individual. And some people have very low psychosocial input, and they may not even be seeing doctors. They're just doing pretty well, or they might just check in occasionally to get a bit of a muscle treatment or something, but they're doing well. They understand what's going on and they self-manage. Probably about 15 to 20% of the total group, we think. Education, exercise and psychological treatments are the essential background approaches, and most guidelines, such as the European guidelines, will emphasise that as the first up thing to do. There's no real knowledge as to which is the best approach. In regard to exercise, all sorts of exercise seem to be important and useful. There's no one exercise that's better than another. I think it's just a matter of getting the person to doing whatever they can do in the best possible way, in the sort of the traditional get people going exercise way. Education is very important, as I alluded to, and psychology may be critical in many individuals to help them learn coping skills, increase control of their life, decrease catastrophizing, and different mechanisms that might be amplifying the fibromyalgia pathways. From the pharmacological point of view, I'll just whip through these fairly quickly. We talk about painkillers, analgesics, the tricyclic medication, the dual reuptake inhibitors, membrane stabilizers, and some other drugs. I'll just mention a few little points about these drugs that you might find interesting. Non-opioid medications such as paracetamol and anti-inflammatories can be useful in fibromyalgia as analgesics. There's no inflammation in fibromyalgia, but anti-inflammatory drugs are very potent analgesics. Patients often prefer the anti-inflammatories. This is a group of 1,000 patients with fibromyalgia. Most preferred anti-inflammatories, Voltaren, Naproxen, Celebrex, Mobic, those things, compared to pure paracetamol. In regard to opioids, they're not indicated in fibromyalgia. There's some studies done on opioid receptors in the brain of fibromyalgia showing that most of those receptors are fully occupied by endogenous opioids of that particular individual, the endorphins. So the patients are already activating their opioid systems, and external opioids don't seem to do too much. So we don't recommend opioids. Many people with fibromyalgia get put on these drugs and cause more problems than help the situation. Tramadol is perhaps an exception because it does have effects on that serotonin noradrenaline system that I was mentioning, and that can be beneficial in some people. I won't go through all the data. Amitriptyline or NDEP is sort of one of our basic drugs because in very low dose, not in the depression doses, the low dose will help pain modulation. So 10 or 25 milligram in the mid-evening, a few hours before they go to bed, so they're not too sleepy in the morning. About 40% of people will improve. Takes a few weeks to work. Number needed to treat is about 4. A lot of people get tiredness and dry mouth and can't tolerate it, but it's worth persevering with those simple drugs if possible because we don't have a lot and we don't want to maximize what we have got. Got about 5 minutes before I'll stop talking and look at some of those questions. So drugs that are very effective on the noradrenaline side of the equation are useful. So duloxetine Cymbalta works well in fibromyalgia. Milnacipran works well in fibromyalgia. This is the first drug to be approved by the TGA in Australia for fibromyalgia. It hasn't been released by the company because it's not yet approved for PBS, on the PBS, so there's no subsidy for it. But it's been approved. It's amazing. It's been approved last year. But drugs like Zoloft and Prozac that are very powerful on serotonin and great for mood do not affect fibromyalgia. If someone's on one of these drugs, they may also need to be, one of these other drugs may need to be considered if they have depression plus fibromyalgia. I've gone through some of this. I'm just going to whiz through it a little bit. Another set of drugs that are useful are the pregabalin Lyrica or gabapentin medications, which act on the alpha-2 delta ligands. Now, these act on calcium channels in neurons that are overexcited or sensitized, and they bring it back to normality. They don't take it lower than normality, so they don't increase or cause side effects, but they decrease the neurotransmitter release of glutamate, noradrenaline, the substance P, and they're approved for diabetic neuropathy, shingles, and fibromyalgia in various countries. They can have side effects which include dizziness and drowsiness and headache, but they don't have side effects that clash with other drugs or cause significant heart, liver, or whatever problems. So they don't have a lot of key big-time problems, but they have a lot of nuisance problems. But again, in trials, very few people withdraw from these medications. So it's useful to persevere with them. And these drugs work well. They work within a week. They should be getting an improvement within 1 or 2 weeks. And the rule of thumb for drugs and fibromyalgia is that 30% of people get a 50% improvement in pain, and 50% of people get a 30% improvement in pain. If you work that out, 50% don't get any benefit. But the people who do respond may be very usefully helped. I'm just going to whiz through these little ones. I just mentioned sodium oxybate. Sodium oxybate is the so-called date rape drug. So this is very effective on sleep, and it's taken last thing at night. Then in the middle of the night you wake up and have another dose because it's short-acting. It's very effective in fibromyalgia, very effective. But because of the abuse potential, it's not been marketed or approved in any country at this stage. But it sort of links clues to getting better sleep as a way of helping fibromyalgia. And there's a lot of other treatments that are coming on board, combinations of drugs, marijuana, cannabinoids, that sort of drug class are also very useful in early trials of fibromyalgia. I'm not recommending it, but I'm just saying that's out there. Drugs that don't help, cortisone doesn't help. Magnesium in trials doesn't help. Guaifenetic acid, which is sort of a cough mixture which was thought to be beneficial in trials, did not work. And caution must be used when we're using muscle relaxants and hypnotics in fibromyalgia, such as the Valium and temazepam type group. Just be very cautious about those drugs. So our management plan is to do a complete physical examination, identify the widespread abnormal tenderness, look for mimicking diseases, check for any red flag diseases like weight loss, fever, previous cancer, something like that. Is there something else happening? Make sure it's only the fibromyalgia. Check routine blood tests. Make sure everything's pretty much normal. You don't have to do 1,000 tests, but just basic things. Other tests as indicated. Check what the main problem is, assess for comorbid conditions, and then we start off with our education, helping people understand what's happening, exercise, treating any pain generators, but not focusing just on treatment of pain generators, treating the whole person all the time, psychological strategies, and medications you might need, analgesics or some of these newer medications I've mentioned. If patients have got a mood disorder, that will need to be treated independently. I can't read that, but this will be available when the slides are up on the web and you can look at them later. But just to wrap up on the actual overall overview picture, fibromyalgia is a common musculoskeletal related pain syndrome, very common as I've indicated. It has very characteristic clinical features. It's associated with a very significant health impact. It has a variable prognosis. I didn't mention one of those previous slides. I think we have to be positive about the prognosis of fibromyalgia. The worst thing you can say to someone is, oh, gee, you've got fibromyalgia, you're a goner, life's going to be bad now. It's a reversible condition, and the majority of people will get benefit and reversing of their symptoms over time. It associates with distress, and that may need to be particularly focused on in management. And there are a number of new emergent treatments coming, and multimodal management is the key to success. So that's sort of the background. A bit long, but a few things to think about, I guess. There's 1,000 questions here that I have to answer now. So we'll start off, go through them quickly. What have we got? I'll just go from the top. What causes the cognitive change in fibromyalgia? Well, as I said, it's a bit unclear, but probably relates to pain-related chemicals and their effect on brain processes, such as memory and recall. The cognitive dysfunction in fibromyalgia is totally reversible. It's not an early sign of dementia or anything like that. So people who are thinking that way shouldn't worry too much. I should also mention a lot of these symptoms we've been discussing are common in all of us at different times. And I think what we're seeing with fibromyalgia is a compilation of all of these things that are happening a lot of the time, and we've then put a label on it and say you've got this condition. But we all get aches and pains and fuzzy memories and under stress. You know, we get a bit of irritable bowel and this, that and the other. So a lot of these things are common variations in all of us. It's just that when it happens all the time that you might need a more focused approach to management. Vanessa says, does fibromyalgia drop off with age after the midlife onset? Well, it does, yes. Statistically, it does. There's often a high point with fibromyalgia around the early menopausal years. As I said, most clinical trials, the mean age of women is 51 in clinical trials, which is the average age of menopause in Australia. So there may be hormonal factors that are modulating the pain system as well, and that relates to estrogen effects. A question here, my fibrostem seems to be increasing with age after beginning in childhood. Well, I think it might increase over the first few decades, but we'd expect it to drop off later or earlier if you get good management strategies. Question, my understanding from many years ago was that there needed to be a certain number of trigger points active as criteria for diagnosis. That gets back to this discussion of trigger points and tender points. Trigger points are little focal tender lumps in our muscles that we've all got around our neck. If we prod, we'll find a few right now. Just, oh, there's one. And they can generate local pain or referred pain, and sometimes they're quite severe and need specific treatment from your therapist. But tender points aren't trigger points. Tender points are just spots in the body that are abnormally tender. Normal structure, just abnormally tender to simple palpation. And there's some spots that are a bit more tender than others, and we call them tender points. So, yep, you do need a number of tender points to diagnose fibromyalgia, but the newer criteria have got around that and making it a bit easier for us all. Where can we get that sheet? Is that the sheet I put up? We can get that to the Arthritis Victoria for you to have. The assessment form. Actually, I might mention there's an article on fibromyalgia in the latest Medical Observer last week, which was written by our team here, and we've got that sheet right in there. So if you've got the Medical Observer from last week, you might be able to download it. You'll have that sheet in there as well. I've got a question here. Given most of the management strategies you proposed, would this patient population be best suited to a chronic pain program? Well, it is a chronic pain condition, and yes, a chronic pain program would be beneficial for fibromyalgia. I think you just, there's a bit of the chronic pain syndrome and fibromyalgia. I like the term fibromyalgia because you put a label on the condition. You can then go to the research areas and see all of this stuff that's been written about fibromyalgia and all the different trials, and you can take positive things out of that. With chronic pain syndrome, there's really no specific diagnosis for that. It's just a sort of a lumping term. So I like the term fibromyalgia, and you might have to hone your pain management program to the things that link to fibromyalgia, not to other chronic pain conditions. But in general terms, there's similar principles to treat other chronic pain problems like TMJ pain or regional pain or whatever, as it is in treating fibromyalgia. Is fear a feature of free-floating anxiety in fibromyalgia? There is a lot of fear in fibromyalgia. A lot of anxiety is in the background of many people with fibromyalgia. A lot of people are fearful of doing things. They might hurt themselves. They worry that pain is a sign of injury or you've got to pull back from the pain. This is all part of the education and getting people exercising sort of approach, not being fearful of the pain but rather pushing into it and being, respecting pain but pushing into it rather than stopping doing anything. A lot of people in work situations are fearful of pain, often relates to control. Someone else is controlling their life, it's best to try to get people to control their own life, and that's the whole principle of self-management, getting people back in control. Are there any multidisciplinary clinics in Melbourne for fibromyalgia? Well, the only hospital in Melbourne that runs a fibromyalgia clinic is here at Monash, and the waiting list is now 2 years. 2 years, I heard yesterday, and the health department's complaining. The waiting list of 2 years is ridiculous. But there's lots of people who independently deal with fibromyalgia, and I think most people who are in the health management area will see fibromyalgia. As I said, it comes in all different shapes and forms. It's always around us, and we have to develop our own little groupings of people. So if you're a physio, you might have your local psychologist, or your myotherapist, or you're a GP, or you have a grouping of people who are understanding of fibromyalgia that you might link that patient to, depending on their needs. So you have your own clinic, if you like, your sort of virtual clinic in your community. There's the pain clinics around the state are also overwhelmed by chronic pain situations. Any data on the effectiveness of massage in fibromyalgia? Yes, massage can be very useful, usually lighter massage, because people are very sensitive to too much stimulation. It might actually aggravate the situation. But I think if you're doing things like massage, you have to combine it with getting them exercising and stretching and understanding what's driving the problem, because they can keep coming back and just having, oh, gee, that feels great, I love a massage, but you want to also have it in a program that's going to lead them out of that path of pain, as we say. What are your thoughts on fibromyalgia as a psychological disease? Well, this is the great dichotomy of psychology and physical side of things. It's not one or the other. The body's linked. The brain links to the body through different nerves, and some of those are sensory nerves, and they're modulated by the brain. So, I think psychological factors are very important in fibromyalgia, but it's not a psychological disease as such. It's really a way the body changes its function in the context of different central distress psychological impacts. That's how I see it. A lot of people with fibromyalgia have no abnormal psychology, though. They're just typical, everyday, can-do people. But maybe it's the way, maybe there's things we need to know more about that at this stage. Go on about that. What do you think about coenzyme Q10? I haven't seen any trials with that drug. I think with any drug in fibromyalgia, you've got to trial it to see if it works. It'll be a proper clinical trial. Otherwise, it's a lot of placebo effect occurs in fibromyalgia. And of course, we might take coenzyme Q10. My wife brought some for me to take, but I haven't taken them yet. But she does. So a lot of these things may or may not work, but they have to be trialed before we really can say they do or don't work. I just noticed in a bulletin today that creatine has been trialled in Brazil, showed a positive result in fibromyalgia. So that's early. There's only a small number of patients, but it was positive. So there are things out there that may not be fully trialled, but that shouldn't eliminate them from our thoughts. Vitamins, acupuncture. I was partly involved in a Cochrane review on acupuncture and fibromyalgia from Zheng at RMIT University. And there are some positive things about acupuncture and fibromyalgia, but it's very hard to design trials appropriately to really say if someone has real acupuncture or fake acupuncture in that setting. So a lot of these things need to be more fully explored. How do you reverse the condition? Can you give an example? Well, I've had a number of people who have come back over the years who had very bad fibromyalgia. They come back and they've got some other problem. And I think what reversed it in a lot of those people was a cessation of some stressful event in their life. It might be problems with the marital or children or financial or whatever. When those problems are resolved or the individual decides this is not a big issue, often the fibromyalgia will improve. So I'm heavily psychologically biased in regard to outcomes with fibromyalgia. Medication and other treatments can also improve it considerably as well. Do you think it's overdiagnosed by GPs as a way of dealing with difficult patients, giving them a diagnosis? I don't think so. I think GPs are often reluctant to use the diagnosis of fibromyalgia. And has to be used carefully and after a lot of thought about the individual. But I don't think it's just a throwaway term. I think if someone's got fibromyalgia, that's what they've got. They might have tension headache, that's what they've got. They might have, anything, pelvic pain syndrome, irritable bowel syndrome, irritable bladder syndrome, all of these sort of things are good diagnoses as long as you do something about the diagnosis. What would be the first option for pharmacological management? I think most of us would start on a very simple, low-cost amitriptyline type preparation in fibromyalgia. Usually by the time a doctor sees them, they've tried their Panadol and maybe anti-inflammatories from the chemist, Nurophens, etc. And if they work, obviously they're not going to come and see you. But once they've gone past those simple analgesics, you might then be trying to modulate the pain system with something like amitriptyline. And that'll help, as I said, in about 40% of people if they can tolerate it well. Is there a correlation between Epstein-Barr virus, glandular fever and fibromyalgia? Probably not. It's probably just a trigger. Like if someone gets glandular fever, it might be the trigger for aches and pains which persist and then develop into the fibromyalgia clinical phenotype and have ongoing problems. I don't think there's any evidence of, in any conditions, that there's ongoing viral infection causing fibromyalgia. Can you distinguish between the features of chronic fatigue and fibromyalgia? Well, often there's a big overlap and about a 70% overlap of symptoms. And the new criteria for fibromyalgia will loop in a lot of those chronic fatigue patients as being fulfilling criteria for fibromyalgia. That depends where you're coming from. If you're seeing a musculoskeletal type person, you probably have fibromyalgia. If you're seeing someone else, you might have chronic fatigue. But I think at the ends of the spectrum, there may be pure chronic fatigue and pure fibromyalgia, but most people overlap. And it probably doesn't really matter in the long run as long as you treat them appropriately, and the treatment's about the same. Importance of exercise, retraining movement patterns to assist everyday tasks. From what I read about exercise, it doesn't really matter what you do. Most things will help as long as someone does the exercise. Walking, swimming, bike riding, stretching, gym, muscle, light weight work, whatever. As long as you're doing something, getting some aerobic and getting some muscle work, it seems to be beneficial in desensitizing a lot of these pathways that activate in fibromyalgia. It also helps release chemicals in the brain, not only the endorphins, but other chemicals such as relate to the noradrenaline type things that help in fibromyalgia. Can you comment on motivation and self-management for patients? Well, that's a key. That was hidden in one of those slides I whizzed over. Attitude of the individual, the willingness to improve is key. If you can motivate people into tackling those sort of issues, you're halfway there with a lot of the approaches to management. I don't have any key clues to give you right now as to how to do that in some people. Does the gut flora have a health effect in fibromyalgia? Haven't seen any reports of links between gut flora and fibromyalgia. Obviously, looking at gut flora and lots of other conditions is an extremely interesting area. I doubt if it'll be a major issue in fibromyalgia. I think it's driven from above. Maybe people with irritable bowel might have gut flora issues, which then the fibromyalgia sensitization process makes more symptomatic. Maybe there'll be links that way, but we'll have to wait and see. Helping people stay motivated. Can we get a copy of the PowerPoint? Yes, I think the PowerPoint presentation will be available through Arthritis Victoria in due course. Can fibromyalgia increase susceptibility to infections or low immune system? Not that I've seen. Not that I've seen any report that there's increased infection rates in fibromyalgia. So there are changes in the immune system in fibromyalgia, but they're probably consequent upon the activated pain pathways and neuropeptides that are released rather than a cause of the problem. I don't think they cause any intrinsic susceptibility to infection. Questions are finished.
Okay. Well, listen, on behalf of everyone, I'd like to thank you very much, Geoff, for a most informative presentation. I'd like to thank everyone sincerely for also their involvement and the extensive list of questions at the end, which were fantastic. Yes, everyone will receive the link to this webinar and also a copy of the presentation. And could I ask that people now direct their attention to filling in the exit survey? And again, Geoff, thank you very much. And thanks everyone for joining our webinar today. Thanks and goodbye.